So good morning, my name is Malcolm West. I'm a NIHR clinical academic working in the University of Southampton, and I'm also a general surgical colorectal trainee in Wessex in the UK. And within the next half hour I'll be talking to you about cardiopulmonary exercise testing, or CPET, and prehabilitation in the perioperative setting. So there are about 4 million surgical procedures performed annually in the United Kingdom, with a various morbidity and mortality ranging up to 25% in morbidity. 12% of these patients are already labelled as high-risk individuals, and 83% of those are responsible for total mortality and length of hospital stay. When considering rectal cancer resections, published morbidity can be up to 40%. When looking at epidemiological literature, there is a very strong link between surgical morbidity and reduced survival. In the surgical literature, however, there is poor reporting for this morbidity. So for us surgeons and perioperative physicians, the major challenge is to identify these high-risk individuals and optimize their post-operative course. So when looking at a cardiopulmonary exercise test, this is a figure taken from Principles and Practices of Exercise Physiology, edited by Carl Wasserman from UCLA. And essentially it shows that we measure oxygen uptake and oxygen and carbon dioxide output at the mouth using a cardiopulmonary exercise test. And this is tracked all the way down the oxygen cascade into the mitochondria, which are the site of interest. And this test has been popularized in the 1990s by Professor Paul Older in Australia, and it is now gold standard to link in physical fitness and stratify risk for perioperative outcome. And in his seminal paper, Paul Older in Chest of 1983, he said that low physical fitness determined by CPET is linked to poor patient outcome. As you can see from the picture, this is an elderly gentleman with advanced rectal cancer waiting for his operation. He is undergoing a CPET test, and he is currently pedaling on an exercise bike and is attached to non-invasive blood pressure monitoring, arterial saturations, a full 12-lead ECG and a tight-fitting mask to measure his oxygen uptake and carbon dioxide output. So CPET is defined as a non-invasive graded exercise challenge, which is performed on a cycle ergometer. It can also be performed on an arm crank or a treadmill. However, in patients who are waiting for an operation, I think cycle ergometry is much better as it's weight supported. This allows the objective assessment of physical fitness and at rest and under stress, mimicking the stress of major surgery. And in the literature in the last 10 years, there have been a flurry of papers looking at the optimal predictors between different surgical types. We've looked at the oxygen uptake at lactate threshold or the anaerobic threshold with the magic number of 11 mils per kilo per minute in major intra-abdominal surgery. We've also looked at the oxygen uptake at peak and the ventilator equivalents for carbon dioxide, which are indicative of perioperative risk and can stratify according to outcome. So what is prehabilitation? Prehabilitation has been popularized by the Montreal group, the Carly group in Canada, and this is a form of exercise training that is aimed to prevent injuries before they actually happen. We prehabilitate from before major surgery, before thoracic, abdominal or orthopedic nowadays, and after neoadjuvant cancer therapies. And why prehabilitate? I mean, traditionally, as surgeons, we have focused on the post-operative recovery process and intervening after and around the major surgical event using the enhanced recovery pathways. And this is one of the papers from the Monson group in Hull, looking at a systematic review and meta-analysis of this. However, the preoperative period may be a more emotionally salient time to intervene, as patients can be actively engaged in their operative recovery and in their operation. Rehabilitation has been done for decades in heart failure patients, in post-MI patients, and also in respiratory patients post-COPD exacerbations. However, the evidence is quite scanty. We have published a review in Best Practice in Research Clinical Anesthesiology in 2011, and we have published a systematic review in the BJA of 2013 looking at this evidence. These are two other papers by Vignette in 2010 and by Singh in 2014 in Western Australia, looking at the pre-surgical exercise interventions in a cancer population. This is one of our tables in our recent BJA paper that shows there are very small number of patients in about 10 randomized control or observational trials with a number of about 520 patients. These studies we thought were badly designed, lacked power. However, their intervention improved fitness. And why have we been doing this in the UK? This is my experience that we've been doing prehabilitation since 2010, and this is the experience of the FIT4Surgery Consortium led by Professor Mike Grocott in Southampton. Our aim was initially to look at CPET variables and predict their in-hospital morbidity in patients undergoing major colonic and rectal surgeries. We have different papers which I'll show you, looking at colonic surgery, both benign and malignant, rectal cancer surgery, and colorectal and upper GI cancer patients after their chemotherapy interventions. This is one of our first papers, the colonic surgery paper. These are 133 patients, both benign and malignant group. And as you can see from the receiver operator curves, the cutoff for oxygen uptake at lactic threshold and at peak are similar to the published literature, around about 10 or 11 for the anaerobic threshold and 16 for peak, which have a good sensitivity and specificity and relate to in-hospital short-term outcome. We then looked at a risk prediction model for these colorectal patients, and we can see that if you're a male, you have a 4.5% chance of morbidity post-surgery. If you have an oxygen uptake of around 11 and you are able to increase that by 1 point, you can reduce your odds ratio by 25%, so your risk declines by 25%. If you are able to improve that by 2 milligrams per kilo per minute, your risk of in-hospital morbidity falls by about 40%. The operation type is also important, and with patients having an open resection, this goes up by twofold. We can look at a multivariable model, and the risk prediction model is currently now used in Aintree Hospital in Liverpool, based on gender, anaerobic threshold and operation type, and this gives a better sensitivity and specificity and a better prediction when looking at in-hospital morbidity. This is the paper from the BJA in 2014, which I encourage you to read. When looking at rectal cancer surgery, these are rectal cancer patients only, with having a major surgical operation. And as you can see, the sensitivity and specificity around the measurements is much increased, so the CPET test is more predictive in rectal cancer surgery, we think. This is another risk prediction model which we use, and based around the anaerobic threshold and the oxygen uptake at peak, and these are quite staggering numbers. So we're saying here that if you are above the median of 11 mils per kilo per minute in your anaerobic threshold, your odds ratio or your risk declines by about 95%, whilst if you can improve your VO2 peak by 1 point, your risk reduction is 25%. And this is reflected by the Kaplan-Meier curve for length of hospital stay, in that if you have a complication, your length of stay is much longer, almost double, as opposed to people having no complications. And this is the paper, the citation from the BJS in 2014. What about patients undergoing neoadjuvant cancer treatment? So we've looked at two groups. This is an upper GI neoadjuvant chemotherapy group. These are 38 patients tested both pre-chemotherapy and post-chemotherapy, and having a 6-week course of platinum-based chemotherapy compounds. And as you can see, there is a clinically and statistically significant reduction in their physical fitness by about 2 milligrams per kilo per minute, which is quite acute in a 6-week period. if you can look at the Kaplan-Meier plots, if you a FIT group above the magic number of 14 in this case, you will live for longer as opposed to being below the cutoff point at 1 year. And this is the paper reflecting all the upper GI data published in the European Journal of Surgical Oncology in 2014. We've done exactly the same with neoadjuvant chemoradiotherapy in locally advanced rectal cancer patients, and we've tested them pre and post chemoradiotherapy within a 6-week interval. These patients received a standardized course of chemoradiotherapy, and all these patients were T3N plus circumferential resection margin threatened cancer patients. So quite advanced disease, however operable. And we've seen exactly the same thing, that the lactate threshold or the anaerobic threshold has fallen by 1.5 mils, which is both clinically and statistically significant. And we've also published this paper in the European Journal of Surgical Oncology in 2014 for your reference. The take-home messages from our FIT4Surgery Consortium are that oxygen uptake at lactate threshold or the anaerobic threshold and the oxygen uptake at peak exercise are independently related to 5-day post-operative morbidity, so in-hospital short-term outcome. Fitness declines with neoadjuvant cancer treatments, and these data are taken to be unique, strongly clinically meaningful and attainable when considering the use of a prehabilitation program in major cancer surgery. So how have we been doing this? This is our prehabilitation experience from the FIT4Surgery Collaborative. This was well taken up by the BBC, and all these citations are freely available on the web. These are very good articles published by the BBC World Service, and I urge you to read them. They have quotes from a couple of our patients which are quite emotionally touching. As you can see also, the Royal College of Surgeons, both in Edinburgh and in England, have launched their exercise campaign to reduce mortality by 5-fold, which I think is very salient in this climate. This is a recent press release from the University of Southampton looking at our prehabilitation program. So when considering the rectal cancer prehabilitation program, so my work in Liverpool and in Southampton, our aim was to evaluate the effect of neoadjuvant chemoradiotherapy and a 6-week structured responsive exercise training program on CPET outcomes, namely VO2 at lactate threshold in these locally advanced rectal cancer patients. These are the methods, as you can see. These are 39 patients which were all underwent a CPET test at baseline. Within a week they underwent standardized long course chemoradiotherapy for 6 weeks, and after that they immediately undertook a CPET test again, which was considered week 0. They were then split into an exercise and a control group in a non-randomized controlled way. The exercise group included 22 patients, the control group included 13, and they had exercise versus control for a 6-week group, for a 6-week period, and were followed up until their surgery at week 15. All these patients had standardized chemotherapy and had a standardized T3N plus circumferential resection margin threatened cancer. This is the training program. These patients underwent 18 sessions with 3 CPET tests embedded within the training program. The training program lasted for about 40 minutes, 3 days a week for 6 weeks. And the adherence of this group was phenomenal, which was 94% for all CPET sessions, for all training sessions and CPET sessions, with 0 adverse events. This is a more in-depth look at the exercise training program. This was an interval training program with moderate and severe intensities based on the cardiopulmonary exercise test at week 0. So this was all tailored medicine. And the patients went exercise in a moderate and severe strength intensity based around their lactate threshold. These are the visual outputs from the exercise bike. This is an Ergoline OptiBike. It's essentially a bike that you can find in a gym. However, you can preload an exercise training program on a chip and pin card. This is the visual output that the patient looks at on completing their exercise program, with heart rate as an undulating baseline and the blocks of workload in the background. These are the patient characteristics for the rectal cancer patients. As you can see, the control group was older, were considered to be sicker, and had a WHO performance status which was worse than the exercise group. This is a busy slide. We're looking at all the outputs from the cardiopulmonary exercise test, and if you can look at the column on the right, which shows the significant, level of significance. This is a compound symmetry covariance analysis, which looks at the individual time points and compares pre-chemotherapy versus week 0 versus week 6 with one p-value. And as you can see, we had statistically significant changes in anaerobic threshold, oxygen uptake at peak, O2 pulse at lactate threshold, O2 pulse at peak, workload both at lactate threshold and at peak, and we have also found a significant reduction in heart rate both at rest and at peak exercise. This is a graphic interpretation of that data, looking at oxygen uptake at lactate threshold and between pre-chemotherapy, post-chemotherapy and week 6. And as you can see, patients declined in their fitness losing about 1.9 mils per kilo per minute. However, within 6 weeks that was regained, and the exercise group, which is the dashed line, went back to their original baseline. However, the control group kept losing fitness. And exactly the same thing happened when considering oxygen uptake at peak. This is the change in fitness over the whole exercise program between week 0 and week 14. You can see that patients improved as early as week 3 in the exercise group, and there was already a positive inflection in the exercise group as compared to the control group. The exercise group undulated and went back to baseline at week 14 when we operated on these patients. However, the control group unfortunately kept on losing their fitness and had a fitness which was predicted to be predictive of complications. These are individual patient data. On the left you can see the oxygen uptake at lactate threshold between post chemotherapy and week 6 in the control group, and on the right you can see the exact same for the exercise group. As you can see, you can split these patients into responders and non-responders. There are either patients who have a good response to exercise or patients who don't have a good response to exercise, and maybe that's linked to the exercise challenge that we've provided them with. This is a physical activity graph. We've given these patients a triaxial accelerometer, activity monitor, measuring all sorts of variables. However, the best variable to look at is the mean number of steps, which has declined between pre and post chemotherapy. As you can see, these patients are baseline unfit with about 5,000 steps per day, as opposed to healthy human beings which should have a step count of about 10,000 steps per day. This has dropped between pre and post chemotherapy, and as you can see, both the control group and the exercise group have regained their original baseline activity. However, this is interesting when compared to the oxygen uptake CPET variables, in that the exercise stimulus provided to the exercise group is the only accountable force that drives their improvement in physical fitness and not their physical activity. You can read all this in the British Journal of Anaesthesia in the February edition published in 2015. So what is the clinical relevance of all this? I think these patients get a change in behavior towards exercise, which is well documented in both of our papers when looking at their quality of life, both objectively and subjectively. We have also looked at the effects of neoadjuvant chemoradiotherapy in the same cohort on mitochondrial function. This is a novel way of looking at in vivo mitochondrial function, looking at using something called 31-phosphorus magnetic resonance spectroscopy, or 31-PMRS for short, and whole body CPET measures. We are the first group that has ever done this in a cancer population. As you can see from the pictures on the right, this patient has rectal cancer and is exercising within the bore of a 3 Tesla MR scanner with a phosphorus coil strapped to his right leg. And the phosphorus coil gives us something called KPCR, or phosphocreatinine recovery time constant, which is an in vivo measure of mitochondrial function. This can be easily related to oxygen uptake, both at peak and at anaerobic threshold. And as you can see, this is a randomized controlled trial of n equals 12, and we've split these patients into the exercise group and the control group with exactly the same exercise stimulus as previously. And you can see that the KPCR has declined between pre-chemotherapy and post-chemotherapy, which correlates very nicely to their VO2 at peak and their at lactic threshold. When these patients were split into the exercise group and the control group, you can see that on the left, in the exercise group, these patients have restored both their whole body oxygen uptake levels, and this has mirrored quite nicely with their KPCR function. So their mitochondrial function within a very short period of time has declined and then overshot the baseline, as opposed to the control group, who haven't had any training, and their KPCR is almost exactly the same, which mirrors quite nicely their oxygen uptake variables. And you can read this in a recently published paper in PLOS ONE in 2014. So in conclusion, preoperative exercise training is a valuable intervention to improve physical fitness post-chemotherapy prior to major elective cancer surgery. Preoperative exercise training with different intensities and durations needs to be explored further. Added benefits and clinical relevance is the change of behavior that these patients have towards exercise in the long term, their improvement in quality of life, and their improvement in activity levels, which we have measured. This may have important implications in improving surgical outcome, and we're looking at this using an upper GI cancer cohort and a lower GI cancer cohort, both observational and randomized controlled. This is NIHR-funded, and hopefully the results will be out in 2016, as the trials will end this year. And there is a need to explore potential mechanisms for this decline in physical fitness with neoadjuvant cancer treatments, and the improvement with prehabilitation also needs to be explored, as we have no idea what the mechanistic driving force is behind that. These are my acknowledgements. I would like to thank the FIT4Surgery Consortium, the University of Southampton, our funding partners, which are the NIA and the National Institute for Health Research. Thank you very much for listening.